Hello and welcome to Healthcare Voices, where we bring you authentic voices behind healthcare innovation and impact. I'm your host, Katherine Cummings, former clinician turned healthcare technology advocate. And today I have the great privilege of speaking with Bill Cantrell, former paramedic, critical care and trauma nurse, and founder of ResusMed, an educational institution that aims to elevate the standards of nursing care and practice all over the world. I'm thrilled to have him on the podcast today. Thank you so much for joining me, Bill, and welcome. I'd love for you to start by sharing a little bit about your background and what inspired you to pursue a career in healthcare.
It really started when I was in high school, and I started one of my friends in the neighborhood. His dad was a assistant chief at the fire department, and really started hanging around the fire department, going on some fire calls, did ride-alongs. There was an ambulance base there. Really fell in love with the excitement of the EMS. Was really kind of planning at that point on doing med school in either emergency medicine or anesthesia. I ended up, when I came out of high school, I started working on prepping for pre-med, looking at, thinking about med school and going down that pathway. Nursing was a great option for me because I would gain both clinical skills, would be able to earn money to help support both financially as well as advantages clinically for med school. So I started down that path. Once I graduated from nursing school, I was in Greenville, South Carolina, my hometown. Ended up going to Columbia, South Carolina to take my boards. And so I was driving around with a friend. We were looking at different hospitals in the area, looking for opportunities, a way to get uh, out of the hometown and go out and see the world. I saw the helicopter program at Providence Hospital in Columbia and fell in love with it. I started pestering the ER manager pretty much on a daily basis about getting into the ER because that's what I wanted to do. And it was a different time in flight nursing in that there really weren't a lot of standards. There were lots of crashes. And a lot of the folks in the ER really didn't want to be on the helicopter. They had families, kids. The excitement had kind of worn off. I was coming straight out of school, just an adrenaline junkie. Sometimes was amazed that I could get in the door with my head as big as it was from just the ego. And they didn't hire graduate nurses into the ER, so they parked me in telemetry. So I was on telemetry for about 45 days until I got my nursing results back, and I was an RN at that point. About 3 weeks later, did my first flight after orientation. So I jumped into it really pretty much would be unheard of now. And it was a different time in the programs. I mean, one of the times I can think that we flew a burn patient to Medical University of South Carolina, and the ceiling at that night and the visibility was so bad, we had to come home that night following car headlights up the interstate. So those times are long gone. The programs are much safer. It's one of the nice things with nursing that you can reinvent yourself. And I've been able to do that a number of different times. I've done everything from shock trauma ICU, open heart recovery, cardiac cath lab, cardio electrophysiology, lots of ERs in between, everything from small critical access up to large level 1 trauma centers. I think the largest ER that I've worked at had over 100 beds in it. So some really kind of the full range. And, since then, I've kind of ended up migrated and doing a lot of teaching in the later years. Now I run ResusMed. We do full training for a number of different courses. I really evolved into my role with that. I was traveling around the Pacific Northwest. I was teaching lots of ACLS, PALS, BLS, TNCC classes, basically all the alphabet classes that we get required to take at some point or the other. And I was really dealing with about 12 rural remote hospitals and just going around providing them local training, education. And then COVID came around. With COVID, we were one of the first organizations to jump on it when the ENA, Emergency Nursing Association, offered to allow virtual training. Now, over the period since COVID, we've really grown to this year, we offer over 800 virtual TNCC and ENPC classes. We've trained students from essentially all over the world. got 32 of the brightest course directors that I know working with me, helping to teach the classes. And I think last year we did over 5,000 students. This year, we could very well increase that by anywhere from 50 to 100%. So the virtual is really here, and it's here to stay.
So the culture of healthcare is really unlike any other industry. At baseline, there's this desire for continuous learning, for advancing skills and knowledge. And you said it well yourself, there's opportunities to kind of pivot in your nursing career a lot. And as healthcare professionals, we seek opportunities a lot of the time to make an impact, to advance our skills, to advance our knowledge. And I think your company does a really good job at kind of embodying that culture of continuous learning. How does that culture of continuous learning play into how you manage your company and what it looks like moving forward?
We really decided when we started out that we wanted to offer the best training possible. And so, given teaching virtually and teaching in person are really two different cases. When you teach in person, you've got a controlled environment, typically outside the home, that the student can become essentially immersed in that. There's not all the external pulls on them. When we do classes from home, those students, we're really competing with the dog, the cat, the postman, the spouse, pretty much any number of other things. And so we try to recruit our course directors as individuals that are not only knowledgeable in the field, they're entertaining. And there's a real hunger out there for nurses to gain new knowledge and new skills. This is a way that we're able to reach a lot of nurses. We've done classes for folks in remote areas. We've trained military nurses in country, overseas. So we've been able to touch a lot of different lives and bring the training, the highest quality training possible, to that individual where they're at. And the response to it it's impressed me as far as how that nurses have adapted and really something that they're used to. I mean, the first probably 5 TNCC classes that I took was all in person in a very controlled environment. And then when virtual came around, we really ended up inventing a lot of it as we went. There wasn't a lot of the tools that really supported it. Now we've developed our own tools internally. We've really got a better handle on what information those students need to learn, what we want to see them carry out. Beyond just leaving with a card, we want to see them leave with actionable intelligence they can use their next shift at work. We pretty much, during this time, we've found about every glitch in Zoom that's possible. We have found any little issues. We've also had to handle some things that I've never had to deal with teaching in person. We've had students fall asleep during class, which that's kind of the exception. I think all of our instructors are able to keep students awake. It's just the students that we always hated to see, the ones coming off night shift, and they're there trying to take that class that morning, and their heads kind of bobbing around. That's one of the reasons why we started some afternoon classes for the night shifters, just to give them a chance to catch up on their sleep before trying to take a class and learn.
What's been one of the most rewarding experiences for you as a founder?
Initially, it was me kind of doing everything. And luckily, I would love to say that it was my great recruiting and interviewing skills that got me the team that I have today. I think a lot of it was just blind luck. I've got some of the best educators in the field. I mean, some of our folks, around 85% of the educators are masters or doctorates. 65% of us are either faculty with the ENA, which is a very limited, it's the highest level of educator you can get for TNCC and ENPC. Being that person doing it all, you're kind of limited. Now the fact that I can oversee a group, and we're starting to see students come back for their third and fourth renewals through us. So seeing those students grow, seeing their careers advance, seeing their skills advance, and also seeing my educators. We've been lucky to be exposed to some excellent experiences learning how nurses in other parts of the country or world go about their daily activities. We've had classes in which, we're covering the disaster for TNCC, where we've actually had people that were on the ground treating patients at the Boston bombing, at the Country Music Festival, Las Vegas, the Pulse nightclub shooting. So we've had students in some of our classes, and that's hearing some of their stories has been tremendous. Just hearing it from the folks that were actually there. So that's my main joy, is really seeing the organization grow, seeing our reach out to students grow, and seeing some of the effects of that. Seeing students that are again coming back for their second or third renewal with us.
I know that you have a lot of professional experience in critical care, trauma, and I know that you recently published an article in the Journal of Emergency Nursing, which I'll actually post in the description of the podcast for our listeners, for everyone who wants to take a look at it. It was a really poignant message about resilience and the importance of support and connection. I'd love for you to share, we're talking about your professional experience, but there is another side to it, right? There's the experience as a patient. I'd love for you to share a little bit about what that was like, and how that maybe has shaped your practice, and how it shaped how you approach just caring for patients and teaching students as well.
It was an interesting experience for me because all of the areas that I worked in, I had experience with. I mean, I've got family history, genetics, not a great heart. I mean, it's in 2016, I had my first bypass, two vessel bypass to the right side with saphenous vein grafts. From that point, about 3 weeks after that I was discharged, I mean, I popped through that open heart. It was super easy. I mean, I was up out of bed and off at a bound. About 3 weeks after that, I ended up having one or two of those grafts closed down, had to go back in for a couple of stents. I thought, okay, I'm pretty good at this point. I mean, I figure I've got 10 years at least out of, life expectancy for these grafts that, we'll deal with. Well, I was a little bit wrong on that. It turned out 4 years later in 2020, this was right early in the COVID times. Ended up going back in, having the jaw pain, and ending up with two more vessels, a right internal mammary bypass, and then they took about 12 inches of my left radial artery and used that as a graft. I was doing pretty good initially. I was, as opposed with the sick heart, they had a difficult time weaning me off pump, so that took a good bit of effort. I ended up getting some nasty blue toes, had sloughing of tissues, lots of wound care after that. Was doing pretty well. Started having some aberrant conduction. Started having some what we thought was an SVT, supraventricular tachycardia. And again, another area that I've worked in, the cardiac electrophysiology lab, was pretty much expecting just an AVNRT ablation. So the reentry pathway is in the AV node, burn one of the pathways, issues resolved. Turned out when I got in there that it wasn't a SVT that I was in. I was actually in VTAC, something called a VTAC storm. VTAC storm is usually anywhere from 2 to 3 episodes of ventricular tachycardia in less than a 24-hour time span. Well, when they got me onto the table and they saw they were going to try to do a VT, a ventricular tachycardia ablation, I ended up, blood pressure and everything was very hemodynamically unstable. Unfortunately, with being that unstable, they weren't able to do a lot of sedation. So I ended up getting shot 16 times, defibrillated on the table. Most of those was fully awake for. It really does feel like you've been kicked in the chest by a horse. Ended up, they finally intubated me, put me in the cardiovascular ICU. They had tried to do some ablations on it, but the focal site was too close to one of the coronary arteries on the epicardial surface of the heart, so they weren't able to ablate as much as they wanted to control the VT. For the next 23 days, I was intubated on the ventilator. Every time they moved me, I would go into VTAC. So I was getting shocked probably about 4 to 5 times at least a day. It was kind of like it was old hat or routine. It's like, oh, you need to get checked off on shocks. Go stand in front of his door, or go help him turn him, and you'll probably get to shock him. So we went through that, and I didn't really realize. I went into the hospital on December 2nd for the ablation, thinking it was going to be an overnight procedure. It actually turned into a 2-month ordeal. And I started out, and I've got nothing but good things to say about the three hospitals that took care of me: Peace Health Southwest in Vancouver, Washington, Oregon Health Sciences University in Portland, and then Stanford University, the hospital, Stanford, California. As they went through and were shocking me, my wife was at the bedside during this whole ordeal. So every time, she's a physical therapist, so at least in the medical field, and every time she saw them come in to shock me, it was, there was question whether this was going to be the last time. They finally decided that I was too unstable for the Southwest, air flighted me 8 miles to OHSU. I think I got shocked a couple of times in that period of time. Those I don't remember quite so much. I was sedated, intubated. When I got into OHSU, more um, shocks, more ablation procedures, trying to narrow down the area. During this time, my wife, when I'd been sick with the last open heart surgery, my wife, I said, start keeping a diary. If anything else like this happens again, keep a diary of what happened. And so she kept the diary, and I try to go back and read it about at least once a month, just to remind me of kind of where I came from and what I've been through. It's amazing, you don't really realize how, it can grab a hold of you. You're reading through the diary, and your wife in her handwriting saying, well, I doesn't look like he's going to make it through the night. They're not expecting. So I'm like, that's me they're talking about. That's insane. They ended up, during that time, they ended up putting me on an Impella. It's a device that's inserted through a cut down in right shoulder. Basically provides non-pulsatile forward flow of blood, continuous. It's basically the heart-lung machine minus the lungs. My lungs were good. That was fine. They just needed to pump and move blood. That was really what was keeping me alive. I'd been treated so far with lidocaine drips, amnio drips. They had treated me with MAG, pretty much anything to try to decrease the stimulation. They did bilateral ganglion blocks, where they tried to block the sympathetic innervation of the heart to keep some of the catecholamine storm down with that. You kind of wonder, when your patients are in a coma, where does their head go? What are their brains? What are they thinking about? Mine was pretty much, it was vivid dreams. I don't know if I was picking up things in the background and making up stories around it, that would get into loops where, you'd have the same thoughts and the same issue several times. And you're wondering, what do I have to do to get out of the loop? Is it something I need to do? Am I going to have to fix something or do something before it lets me out? Another one that I had, which was a pretty recurring one, it happened probably 20, 30, 100 times. I couldn't even count. One where I was laying on a beach. Beach is nice, happy place. Everybody's happy to go to the beach, laying on the beach. And then all of a sudden, the waves start coming in, and I'm unable to move. And I go through the whole process of drowning. And I go through this multiple times, just repeat. I don't know. I've kind of wondered if what was happening to me in the physical world at that time was respiratory suctioning me out, lavaging me. Was something happening, or was nothing happening? Um, when I finally got extubated on, it's Christmas Day, I believe, at about 2, they had set me up to go. There was nothing else really they could do with the heart at OHSU, and they were thinking they were going to send me to Stanford for a heart transplant potentially. I was ICU delirium confused. I woke up from, once I was extubated. As they started loosening up the sedation, I had started to start having some breakthrough consciousness. And when I was extubated, I thought I'd been in a Mexican hospital being taken care of by nurses who were nuns. During COVID, my wife was not able to visit. She was, up until that point, had been fairly relaxed. So they were going to fly me to Stanford. That was another Life Flight Learjet ride. I ended up, in getting there, family couldn't visit. I'm probably I'm 900 miles from home, and I'm confused, in pain. And so I show up telling them that I've been, in a Mexican hospital taken care of by those nurses who were nuns. They're going through the chart. They're thinking, gosh, she sounds lucid enough. So they're trying to figure out how they didn't pick that up on report. The whole part of in the ICU, it was still the confusion. I would be having discussions with people who weren't in the room. I was convinced that my wife had made me a no code, and every time the nurse would come in, I'd have them go into Epic and check to make sure I was still a full code. It ended up, though, that finally, as I started clearing up, it was just a rush of emotions. I had went to sleep in the EP lab, and I'd woke up, in ICU at OHSU. The 10 hours after I'd been extubated, I got flown to Stanford. Everything was really coming at me pretty quickly. Emotions
Mhm.
were, what's, I can now see how sometimes patients get unrealistic expectations. All I wanted to do was go home. Every time I would
Mhm.
have a call, and I was so weak, I was physically deconditioned so much that I couldn't even really hold the phone. People were feeding me, moving me around. Just from that small amount of time, I've heard that for every day you're in ICU, it takes 2 days of rehabilitation. I would say that's probably on the shorter end because
I agree.
at the end of this time, I couldn't even lift my head. I was being lifted out of bed, rolled around on a mat. So really didn't have a lot of physical capabilities. And I just knew that I wanted to go home. Every time I would talk to the wife, it was crying, begging her to come get me, get a van. I'll just ride back in the back. And just really unrealistic things. I had her contact a friend of mine who's a cardiac electrophysiologist in town to see if they could take me back for some reason. He luckily convinced her that I'm in the right place and I'm where I should be. Um, the whole time during that, it probably went to one of the darkest periods. I'd been taking antidepressants. It's not good to come off of them cold turkey. You tend to get some level of symptoms and rebound. I was, it had been just, I was doing inventory of my life one night in the ICU. Nobody could visit. Everybody was still terrified of COVID. The nurses would come in, gowned up and everything, do their stuff and get right back out. And it really just hit a bottom for me. I started doing inventory thinking, what do I have to be thankful for? And I was thankful for the ice chips that I got. I was thankful for there was this one medicine they gave me for some reason, a PO that tasted like watermelon. So I would savor that medicine. It was the last thing I took and I would enjoy it the whole time through. And it that was pretty much the only things I had to look forward to. I was being pretty selfish and self-centered at that point. I decided one night that, the confusion, the hallucinations, the vivid dreams, I decided that, this maybe I couldn't really tell what was real and what wasn't. So I had an art line in my left brachial artery. It was kind of positional. The nurses were using it just for blood draws. And so they had a cuff on me. They were getting blood pressures. And so one night I decided that I think if I pull this out, if I die, I'll get my answer. And if I wake up, I'll get my answer. So I decided that, after they did the evening care, once they left, I was going to pull the IV or pull the art line or open the stopcock up and I figured it would take me a few minutes, 10. I was already had a low hemoglobin, hematocrit. I'd probably bleed out if I was going to, and at least it would stop all the pain and the issues. And I was waiting there and I started thinking, it's like, this is probably the worst thing that I could do to my wife. After everything we've been through with this, and to do something like that. So that's really the thing that pulled me back from the edge. From there, I started to get some hope. I was improving. At one point, my ejection fraction when I was on the Impella was less than 10%. A normal ejection fraction is about 65 to 70%. So my heart was really just kind of flapping in the wind. And it turned out they were able to do some ablations. I ended up, they got put an implanted cardiac defibrillator in. They got me off the Impella. They got me off the transplant list. And from there, I went back to Vancouver. They flew me back. Again, I should have frequent flyer miles on life right now. They flew me back to acute inpatient rehab. And that was a week of just hard work. That was 4 or 5 hours every day of rehabilitation. I could not walk. I was barely able to use a walker when I came home. Then I'd been down in the hospital at that point for almost 2 months. I just, I wanted to go home, and this was what I had to do to get home. So I threw myself into rehab, and I started basically running the hallways in the walker. So getting the exercise in, and finally got home. And in coming home, I was still on the walker. Lots of, I had developed, since they hadn't been able to turn me, I had two softball-sized decubitus ulcers, one on each butt cheek, that were as close down almost to the bone as possible. They couldn't turn me, so they with the tack, so those developed. That actually was kind of adding insult to injury. It took longer. For probably 3 months after discharge, I was still going to the wound clinic till they finally, everything healed up. I came out of this with both physical and some mental scars. A lot of the things that coming out, the depression symptoms were worse, or attention deficit was worse. Everything seemed to be magnified. And it really took me about a year at home to start feeling normal again. A lot of times, I would wake up and I would be like, am I really here? Or am I still, sleeping in the hospital in a coma someplace? Several things got really driven home to me, from this, things that I learned and took away from it. Of the things that I really got a good introduction to, gratitude versus thankfulness. And as much as we kind of use those sometimes interchangeably, they're really very different. In the case of gratitude's more of a long-term, a feeling, a way of existence or being. Whereas thankfulness is a lot more, it's temporary, it's situational, a lot of times it's transactional. And I really learned to drive in on that gratitude. I mean, until you've had somebody doing everything from, cleaning your bottom to, doing, all the care on you, moving you around, turning you back and forth, saving your life. You learned, I mean, I got to the point, I was thanking everybody that came into the room. Housekeeping, oh, thank you for doing this. Just feeling the gratitude of knowing that there are people that there. The other part was the importance of having somebody in your corner. Before I was extubated, they were thinking of tracheing me. My wife there, saying, hey, let's give him a try to see if he can fly off the ventilator. Her there advocating for me when I wasn't able to advocate for myself, what I wanted. So having somebody there, and I really underestimated the power of family support. Until you're that many miles away, you're in pain, you're lonely, there's nothing to do, you're sitting there looking at the four walls. Your nursing team comes in maybe once every hour, once every 30 minutes, to check on you. It really, stretches some of your coping mechanisms. The other thing that really came to me was there's really not a lot of support systems in place for post-ICU care. We do a great job taking care of the physical, but the mental health afterwards, PTSD, other emotional issues that we really don't. I've seen that, there's some I've heard anecdotally, some hospitals have like an ICU support group for people who survive. And that's, I found that not only did I need that type of support, but, the family did too. They had been, I slept through 23 days, whereas, my wife was in there every single day.
In the last podcast that came out, I interviewed a nurse, Taylor Caldwell, and she brought up a really great point about how nurses, not just patients, suffer from PTSD, and we're often dealing with our own humanity as we take care of patients. So seeing that you have been on both sides, the flight nursing, being in in a trauma space, being in the cardiac ICU as a provider or a clinician, and then being the recipient of care, I'm sure that you view things very differently now that you've kind of had to not only deal with your own humanity from the clinical perspective, but actually as a patient as well. So I appreciate you sharing your story there. Kind of pivoting back to a question that came up earlier on, or rather a topic that came up earlier about this culture of continuous learning, continuous skill building and education. How do you stay kind of up to date on the latest evidence-based techniques to improve nursing practice, especially when you're educating your students?
It takes really a multi-pronged approach. I'm a podcast junkie, listening, going through podcasts. I'm try to participate a lot in social media. I try to write at least one or two articles a week. Now I can kind of focus instead of focusing on what somebody else wants me to do. I can kind of focus on what I want to teach about, things that I'm interested. I do a lot of work with difficult airway classes. I do a lot of work with SALAD, suction assisted laryngoscopy, and airway decontamination. And just to try to stay up on it, foam ed medicine has been a huge part of just taking in information as well as contributing to it. It really you've got to develop it as a habit, and you've got to make it something you're responsible for. Too often nurses are used to, well, they need me to know it for work, and they can send me and train me for it. And you've really got to have that hunger for learning that drives you. I mean, find things that I'll do deep dives into topics. I'll run across something and it's like, why is this way? What's the physiology behind it? And really deep dive into those areas to understand it. So it also helps if you surround yourself with others like that are, where you're constantly learning and pushing each other to new heights. And so that's really the way that I've done it. It seems like that with some of the methods, there's so much you can get a medical education essentially on the internet. There's so much information, so much quality resources, and in the past, you might have to wait, until a study had been written up and finally published in a textbook that several years down the road, you might find out about it. Now, you're able to find out the results of studies, critiques of those studies, hours after their release. So that's been some of the ways that, I've tried to stay up and just to, continue to self-educate myself.
Well, those are all really good suggestions. I'm sure everyone on the podcast will appreciate that, especially I know how active you are on LinkedIn. I see regularly your posts and the contributions to the articles that you're making there. I like to end the podcast with one final question. What is one thing you wish people knew about practicing medicine, or maybe one bit of knowledge that you'd like to impart on our listeners?
I guess one of the big items that we look at is there's lots of shiny new toys and new tools out there. It's almost like medicine's a game of golf. There's a new putter out or new driver out, every week. And the reality is the beginning focus really needs to be on the basics. Everybody, I do a lecture about resuscitate before you intubate, and everybody wants to do let's get that tube through the cords. Let's video laryngoscope versus direct laryngoscopy, all these other things. It's really about the basics. When I was educator, one of the low tech things I would do would be just to take a ambu bag, a bag valve mask, and take it around the nursing units and get people to practice bagging for 2 minutes. That's one of the most underrated skills in medicine, but it's a basic skill. It's things that, we want to jump forward and do all the advanced stuff, but focus on the basics. As new nurses, as I precept and mentor new nurses, it's really about, getting the basics down, understanding the physiology. If you understand the physiology behind the disease process or what's going on with the patient, you're going to be in a far better position to be able to understand new advances, treatments, technologies. So it's really focus on the basics and build on those. It's really hard to try to go. One of the things in talking to a number of facilities that have put in ECMO programs for putting patients on a temporary cardiopulmonary bypass, during cardiac arrest, all the facilities that have taken these, to their emergency rooms where they're actually putting post cardiac arrest patients on ECMO, one of the things they've said is with all the bells and whistles and toys that we've got, when we started to implement them, we realized that we really need to go back to the basics and rebuild from there up. So that's I guess what I would encourage folks that are in healthcare is focus on those basics. And then once you get those down, you've got a good foundation to build your skills going forward.
Well, thank you so much, Bill, for sharing your experience, not only on the clinical side, but also as a patient with us. The passion for what you do and the passion for everything that you've experienced really stands out and shines through in everything that you're saying. So thank you again for joining me, and look forward to continuing to talk to you and seeing what your company does in the future.
Very good. Thanks for having me on.
Thank you to all of our listeners for joining us on the podcast today. We appreciate your support. To hear from more healthcare voices like Bill Cantrell, hit the subscribe button and share this podcast with your friends and family. I'm your host, Catherine Cummings, and you just listened to Healthcare Voices.